But for now, we'll get going with the launch of today's report. It's obviously a really important uh, issue. Hepatitis B is an important issue for a number of priority populations in our country, particularly Aboriginal and Torres Strait Islander people and people born overseas in high prevalence areas. And with that recognition of the importance of hepatitis B and viral hepatitis for people from Aboriginal and or Torres Strait Islander backgrounds, I would obviously like to acknowledge that the lands we're all dialing in from today, wherever we are in Australia, are lands of Aboriginal or Torres Strait Islander people. And I would like to acknowledge elders past, present, and emerging. Here at the Doherty Institute, we're on the lands of the Wurundjeri people of the Kulin Nation. And where I live is the lands of the Bunurong people, also of the Kulin Nation. And I'd like to acknowledge the elders of those communities and of all the communities that are joining us today. And I would particularly warmly welcome any Aboriginal or Torres Strait Islander colleagues who are joining us in today's launch. And thank you very much for your ongoing uh, custodianship of the health response for Aboriginal and Torres Strait Islander people. I also really want to acknowledge the people living with hepatitis B, about whom our national hepatitis B strategy clearly exists to serve and to guide the responses for. We'll go to the presentation now. Please do save up your questions for the end and we'll have time to address those. But for now, I'll start sharing my screen and we'll work through the presentation. Thank you. So I'd like to acknowledge, first of all, Leanne for that welcome and for that really important grounding in why not just the indicators report and our national strategies, but indeed why all of us are working in this space to try and address the needs of people living with hepatitis B. And Leanne, thank you for your ongoing partnership and guidance and keeping everything we do grounded in that reality. I'd also like to acknowledge the National Surveillance for Hepatitis B Indicators Project is funded by the Australian Government Department of Health, Disability and Ageing. Um, and that I'm presenting today on behalf of colleagues working here at the Doherty Institute, particularly Ang Nguyen, who's also online and will be answering technical questions about the model if they arise, but also Nicole Romero, Jennifer McLaughlin, Rasheen McCall, and Beth Hamilton. The data are derived from a lot of different sources, including the ABS, the Australian Bureau of Statistics, Department of Health and Aged Care, and the Department of Social Services, and a vast array of published literature to inform particularly the transition parameters and the impact of treatment in the model. And very grateful for the ongoing oversight and feedback provided to this project by our advisory group here at the WHO Collaborating Centre for Viral Hepatitis at the Doherty Institute. So, as Leanne already mentioned, the Viral Hepatitis Mapping Project annual report was launched on the 9th of April of this year. And Jen McLaughlin, who's online, was the one who spoke to that very appropriately, as she's the one who does almost all of the work in that project from our team's perspective. The National Surveillance for Hepatitis B Indicators Project is the other large annual report that we produce under the auspices of the surveillance program funded by the Department of Health, Disability and Ageing. These are different projects, whereas the mapping report really focuses on right down to the cascade of care at not just a primary health network level, but down to statistical area 3, so population units of around 100,000 individuals, and allows that local analysis and targeting of programs and evaluation of the impact of what's happening on the ground in community and looks at the demographic differences right down at those levels. The indicators report or the tracking Australia's progress towards Hep B elimination is derived from a substantial mathematical model that looks at the entire population of Australia and seeks to project not just the prevalence of hepatitis B, but the impact of control measures both here and overseas, and where we're headed, as Leanne was just emphasising, on our elimination trajectory. And so that's what we're launching today. The website that the reports can be accessed is on this slide. These slides will be made available for those who have registered for this webinar to be able to access down the track. But here at the Collaborating Centre website, both the report and also an interactive surveillance dashboard is available, which allows you to select either nationally or for each jurisdiction, not just the estimates of the cascade of care for hepatitis B, but right down to the different phases of hepatitis B in the population in different groups and the proportions diagnosed and on treatment through all of those. So please do explore those at your leisure, and we are very happy to take any questions that might arise as you explore those. So this work derives from Australia's national hepatitis B strategies, and these have been guiding our response since 2010. And now with the draft hepatitis B strategy, which has a timeline through till 2030, really this is guiding 2 decades worth of response to hepatitis B in Australia. One of the real strengths of our strategic framework in Australia is that clear goals and targets and indicators to measure our progress towards elimination have been included. Even from the time of the first national strategy, where really there was no ability to report against a lot of those indicators, it set the agenda for where Australia was seeking to derive that information with a view to actually being able to report against those indicators and guide our progress. And the Australian government has subsequently invested in surveillance and monitoring through a range of partners and institutes to measure progress and guide priority actions, not just for the hepatitis B strategy, but indeed for the suite of bloodborne virus and sexually transmissible infection strategies over that period of time. So the previous national strategy, which had a period of time up until 2022, had these targets, as you see on the left of your screen. So from prevention, particularly immunisation of infants and reduction of infections, through what's known as the cascade of care. So the trajectory of individuals within the population living with hepatitis B from diagnosis through engagement in care, and then the provision of treatment for those who are eligible for antiviral therapy. All of these elements, as well as the underlying number of people living with hepatitis B in our country, are presented through this modelling work that I'll highlight today. In addition, this mathematical model estimates the mortality of people living with hepatitis B, both all-cause and attributable to hepatitis B, particularly through advanced liver disease, hepatocellular carcinoma, and decompensated cirrhosis. In the draft subsequent national hepatitis B strategy, with a timeline of 2030, these targets were revised and strengthened in many regards and aligned to a significant degree with the World Health Organization Global Hepatitis Strategy, Global Health Sector Strategy targets or goals for elimination of hepatitis B as a public health concern. So these include the 95% infant vaccination, but also birth dose provision, 0.1% prevalence amongst children aged under 5 years, 90% of people diagnosed with hepatitis B, 90% of those who are diagnosed being in care, 27%, and I'll explain where that comes from, 27% of people living with hepatitis B in Australia receiving antiviral treatment, and a reduction of attributable mortality to 1 per 100,000 of the population per annum. So just emphasizing that in addition to those numeric targets for the nation, there are also equity dimensions. And this particularly speaks to the mapping report, which Jen launched back in April, where the targets are considered achieved when all population units, whether it's jurisdictions or primary health networks, and priority populations achieve those goals for the 2030 elimination targets. And just highlighting the close alignment between our national targets and the WHO Global Health Sector Strategy targets for 2030. Noting the quite different mortality target on a global level, really reflecting that many populations are coming from a much higher population prevalence than is the case for Australia as a whole. So just briefly overviewing the model. So in this model, which has been under development and use for 15 years now, but undergoes refinement and revision constantly, each health state is broken down into 18 age groups. The model starts in the year 1951 and runs through till the year 2050 and generates outputs for every year. So there's a range of different disease or health states in the model, which I'll speak to on the next slide. And they model people who are susceptible to hepatitis B, who acquire infection or who are immunized, and then people who progress to chronic hepatitis B and the various phases of hepatitis B within that, so that the impact of antiviral treatment on those individuals living with hepatitis B at those various phases can be modeled. So local transmission is estimated, including mother-to-child transmission. But in addition to which, there is a dynamic population such that in every year we include the impact of migration from overseas into all of those health states, whether susceptible, immune, or living with chronic hepatitis B. And obviously incorporating births into the model and loss of life, whether hepatitis B or all cause, and emigration. And this model has been published in a range of papers, a couple of those at the bottom there, which are particularly sort of significant, particularly the first publication, the hepatology publication. So when we look at the model overview, it's a rather busy slide, but in essence, it's modeling the entire Australian population into these exclusive categories. So for people who do not have chronic hepatitis B, but in those four phases or those four states, whether susceptible, acute infection, immune through vaccination, or immune through resolved infection. And then from acute infection, moving through into the potential to develop chronic hepatitis B, which is clearly different at different age groups and based on that age structure of the model I talked about before. And then people can move through the various phases of transition to other states of hepatitis B, but also responses, including diagnosis, antiviral treatment, and outcomes. So all of these aspects are incorporated, and people migrate into the model in different age strata and in different health states. So there is more information available, and we can direct you towards both the report, where there's a lot of detail on the publication, and the transition parameters that are in the model. So I just want to take you through some of the complexity that underlies the model, and I'm going to use as a case study migration. So this is net overseas migration. So this is people arriving in Australia per year as long-term entrants, minus those who are departing Australia for an extended period. So not short-term travel, but longer-term travel. From that we derive a net overseas migration, which are data provided by the Australian Bureau of Statistics. You can see the impact of the COVID-19 acute phase of the pandemic from 2020 for a couple of years there, but also the historic levels of migration that occurred thereafter. And clearly, this is one of the reasons why the model needs to be updated every year, because when perturbations occur in population movements like this, it has a profound effect on the model. Then once we've got the net overseas migration, we need to think about the different countries of birth and the age structure of migrants from each of those countries, because people are coming for under different categories of travel, and that relates to the age structure of the migrants from that particular country of birth. So that also needs to be incorporated so that those age structures are reflected in the people entering the model based on what's happening in the real world environment. We then derive the chronic hepatitis B prevalence amongst migrants by using a variety of sources. Prior to 1991, countries were really divided into the three low, intermediate, and high prevalence categories. But then for those migrating after 1991, we derive prevalence estimates from the Viral Hepatitis Mapping Project. And now for the top 30 countries of birth, representing 75% of hepatitis B, of individuals living with hepatitis B migrating to Australia, we model individual prevalence estimates by age category so that we're actually able to capture not only the differences in prevalence between countries, but within a country based on the age of migrants, and particularly when they started immunizing their population. And to give an example of the profound changes that are occurring in our region around hepatitis B prevalence. So this is an example of China published just last year in the Lancet Regional Health Western Pacific. So you can see there was a 99% reduction in prevalence of hepatitis B in China over this time period between the year 1992 and indeed by the year 2014. And so, in addition to that change amongst infants, as people age, you can see a significant change is also occurring. And this is sort of focusing on people of childbearing age, particularly women of childbearing age, because we know that the majority of chronic hepatitis B derives from infection at birth. But this also is the peak period of migration, or the peak age group for migration to Australia from China. So between the year 1992 and the year 2020, the prevalence of hepatitis B halved amongst people living in China in that age group. So we need to be able to estimate these changes in the incoming migrants. Otherwise, the model will make no sense whatsoever. It's important to reflect that whilst this has an impact here in Australia in terms of not just the prevalence of hepatitis B, but into the burden of liver disease, including liver cancer and decompensated cirrhosis in the future, just pause for a moment and think about the absolutely profound impact this will have in China, where half the world's hepatitis B-related liver cancer occurs. And it's estimated that over 30 million chronic infections and 5 million future lives lost have been averted through the impact of this one intervention, infant hepatitis B vaccination. I think this will be one of the greatest public health achievements of this century. So then we go through and derive for each age group and for each year of birth prevalence estimates to then read into the model for these top countries, and now we're up to 30 countries where we've included this approach. And then the final area of complexity I wanted to highlight is you can't just look at estimates within a country of hepatitis B prevalence and assume that reflects the hepatitis B prevalence amongst migrants. Because for some countries, and taking the example of, say, Fiji here, you can see that migrants from Fiji over the period between 1950 and 1989, 15% of those people were actually from Northern or Western European, Australian or New Zealander background, and the majority were actually people from Indian background. Now that's important, particularly when we think about the model, because the hepatitis B prevalence amongst those groups is lower than it is amongst Fijian individuals from a Pacific background, so from Pacific Islander background originally. And you can see some other examples there of countries where the cultural and linguistic diversity of migrants can be important to reflect over and above just the prevalence in country. And that's some examples there. In the interest of time, I'll move through. Okay, so that's hopefully given a bit of a taste of some of the complexity of the sort of model as it runs through and how we have to keep reiterating it and revising it every year. So what are the results for 2023 for the Tracking Australia's progress towards hepatitis B elimination? So in 2023, we estimate that just under 220,000 Australians were living with chronic hepatitis B. That's a prevalence of 0.82%. This graph shows again the impact of the COVID pandemic on migration, actually resulting in a reduction in the number of people living with hepatitis B for a couple of years there, but then subsequently returning to the previous trajectory as migration has been restored. It's important to reflect that this is substantially more than the prevalence of HIV and hepatitis C in Australia combined. We also see that reflecting the different demography and priority populations in Australia, the prevalence is very different in our different jurisdictions. And thinking particularly about the Northern Territory in the yellow line there, having a prevalence of 1.8%, reflecting the importance of hepatitis B, particularly amongst Aboriginal and Torres Strait Islander people in the Northern Territory, but with also a range of different prevalence estimates for the different jurisdictions, as you can see at the bottom, with Tasmania having roughly um, uh, less than half the prevalence of the national average. When we look at the priority populations at a national level, this is the sort of composition of people living with hepatitis B, um, ranging from and certainly reflecting that Aboriginal and Torres Strait Islander people, as we were just mentioning, represent 7% or just under 7% of people living with hepatitis B in Australia, but that around two-thirds of people with hepatitis B in Australia are born overseas, often in our region, in other countries with intermediate or high prevalence of hepatitis B. So, for those unfamiliar with the concept of a cascade of care, essentially it's trying to estimate people moving through the trajectories of care, from people living with hepatitis B through diagnosis, being provided care, receiving treatment. So, the numbers for Australia in 2023 are these: that we estimate just under 70% of people living with hepatitis B have been diagnosed, which means over 68,000 people are living in Australia with hepatitis B and they have yet to be diagnosed for their condition. When we look at engagement in care, that's defined as either receiving an annual viral load test, which is something we can derive from Medicare data, or people are receiving antiviral treatment. And I'll come back to the point about frequency of viral load monitoring momentarily. But when we come down to the pointy end of the cascade, if you like, receiving antiviral treatment, so currently just over 27,500 people receiving antivirals for Hep B in Australia, or around 12.6% of the total. But our estimates for the proportion of the population eligible under our current criteria for treatment is around 29%. So most people living with Hep B in Australia who are eligible for treatment are not receiving it. When we look at trends in the proportion diagnosed, you can see that this is quite dynamic depending on the number of people arriving in Australia and the ability of our existing testing and clinical care provision to actually diagnose and engage those people in care or give them the opportunity to be engaged in care. There's a lot of difference by jurisdiction in hepatitis B diagnosis, ranging from a high of just under 80% of people diagnosed in New South Wales, down to other jurisdictions where less than 60% have currently been diagnosed. So I hope you're starting to get a bit of a sense that this is guiding, or these estimates can help guide priority areas for intervention and also identify some parts of our country where there's particularly good uptake of different aspects of the cascade that we can then translate into other parts of the country. When we look at the proportion engaged in care, so as I said, defined as receiving antiviral treatment or having a viral load test in a given year. Our target for 2025 in the draft hepatitis B strategy is 65% and a target of 80% by 2030. But really, this is very stagnant at around a quarter of people currently being enrolled in care, as far as we can detect through using MBS and PBS data. Sometimes the question comes up, well, what if we are less strict about viral load monitoring? And what if we said, well, if someone's having a viral load every couple of years, that's pretty good. We know that just over half of the people living with hepatitis B have had any viral load test in the last 7 years. And when we look at someone having three or more viral load tests in the last 7 years, so around about that one every couple of years, again, we're talking about a quarter of people living with hepatitis B. So this is suggestive that we need to do more, substantially more, to engage people in care, because without doing a viral load, without assessing someone's activity of their hepatitis B, they cannot be determined whether they are eligible for treatment, which, if they are and they don't receive the treatment, puts them at risk of progressive liver disease and poor outcomes, including liver cancer. This is our trend in receiving treatment over the last 15 years and then projected for the next 5 years. Uh, we can see that there was a substantial increase from around 2010 when we were sitting around 4% up to now where we're sitting at about 12%. But that has again leveled off in the last couple of years. So we believe there's many more people needing treatment that are not currently getting it, and we're not keeping up with the numbers who require treatment as we look at these charts. The estimated proportion, as I mentioned previously, requiring treatment is 29%. Again, we see significant disparity between different jurisdictions in uptake of treatment. I'd like to highlight one particular success story here. If you look at the yellow line, that's the Northern Territory. And you can see, starting from a very low baseline in 2010 of around 1 or just over 1% of people receiving antiviral treatment, Northern Territory has come up to being approaching the national average, really between 2013 and now. That's an extraordinary achievement in a jurisdiction where a significant proportion of people living with hepatitis B are Aboriginal and Torres Strait Islander people living in remote areas, many of whom have significant other health priorities, and really testament to the dedication of the communities there engaging with the clinicians and public health workers. And one of the notable examples is the Hep B Pass program, which is being run there over that period of time, really since 2013, 2014 until now. So absolutely awe-inspiring achievement and something that hopefully we can translate to other parts of the country. So this is mortality attributable to hepatitis B in Australia for the last 25 years and projected through till 2030. Now, it is important to note that there has been a substantial reduction in loss of life from hepatitis B, particularly from 2010 through to around 2017 or so. But then, because both the aging of the population living with hepatitis B, but also the failures in the cascade of care that I was referring to previously, with a significant proportion of people who require treatment for hepatitis B not receiving it, we see that the numbers of people living with hepatitis B losing their lives due to HCC, which is hepatocellular carcinoma or liver cancer, and decompensated cirrhosis is actually increasing. We do have a recent update of the treatment impact based on a literature review which has been conducted in the last few months, which has been submitted for presentation at the Australasian Viral Hepatitis Conference in Melbourne, suggesting that maybe the treatment impact is greater than what has previously been modelled. And so hopefully we have some slightly better mortality figures to share, but it is still the case that there's an unacceptable loss of life from hepatitis B due to a failure to engage people in diagnosis, treatment, and care. That said, this shows what would be happening now had treatment not been scaled up to the point where it has. So that top dotted line is where, if no treatment had been put on the PBS and if no one was receiving antiviral treatment, we'd be having double the loss of life that we are currently. So whilst there is more to do, there are hundreds of people every year whose lives are being saved by the impact of treatment currently. And I think that's a really, really important message as well. We don't have a lot of time, and I do want to leave some time for the questions at the end. But I really did want to highlight this fantastic new resource, PLIDA, the person-level integrated data asset provided by the Australian Bureau of Statistics. Jen McLaughlin's our expert in the use of PLIDA in this regard. So any questions about PLIDA, I'm going to gracefully pass through to Jen. But in essence, it's linking a whole lot of different databases at the Commonwealth level and allows us, in a completely de-identified and anonymised way, to ascertain things like health service uptake, tests, treatments, and clinical interventions linked with things like movement and travel, migration, um, loss of life, and census data from the Australian Bureau of Statistics. Also linking the Australian Immunisation Register. Hopefully, in the future, this will also include notifiable diseases such as hepatitis B. But this is opening up the opportunity for us to be able to examine cascades of care by subpopulation and priority populations living with hepatitis B. So particularly thinking about people born overseas and Aboriginal and Torres Strait Islander people who together represent roughly 3/4 of people living with Hep B in Australia. We can't estimate diagnosis as yet, but we are able to interrogate things like viral load, testing uptake, and treatment using PLIDA by cultural and linguistic diversity. So when we do that, and again, this is analysis that was presented in the mapping project, Jen spoke to this earlier in the year, but I think it's really important to reflect that rather than just being able to model at the whole of population level or jurisdictional level, we can start looking at uptake of treatment and care by priority population. And so you can see that, for instance, for the people born overseas actually have higher metrics of treatment uptake and care uptake than when you look at the whole of the total population. But devastatingly, for Aboriginal and Torres Strait Islander people in those third columns there, substantially less than either non-Indigenous Australian-born individuals or people born overseas. And this is for the 10 years to 2023. Similarly, we can look at different regions of birth and look at people who, for instance, received any care, whether that was antiviral monitoring or, sorry, viral load monitoring or antiviral treatment. And you can see there's very profound differences in access to care for people from different regions of birth over the 10 years to 2023. So higher levels of care uptake for those born in Southeast Asia, North Africa and the Middle East, and Northeast Asia when compared to people born in Southern and Eastern Europe or Sub-Saharan Africa or the Americas. So this is really getting down to some of that information for action I highlighted at the start of the presentation. And in fact, picking up on what Leanne said, that this is the point of this project is, yes, to chart our progress towards elimination, but also to tell us where we're falling behind and really as a call to action to address those disparities. So in summary, when we look at our progress towards National Hepatitis B strategy targets for the 2022 strategy, we didn't achieve those. And you can see 2022 is highlighted there relative to the targets at the top of the columns. And at the bottom, you can see the year where we're projected to reach the 2022 target. And so for diagnosis, that's 2042. For antiviral treatment, is 2039. And for care and mortality, sadly, beyond 2050. When we look at the WHO targets, for the prevalence and mortality targets, we have achieved those already, but that's by virtue of being a low prevalence hepatitis B population in general. We are tracking towards the treatment target, maybe by 2045 at this point in time, but our diagnosis target of 90% won't be achieved till after 2050 at this point, with the current trajectory. So in conclusion, I think it's fair to say Australia has made profound progress in scaling up treatment and care for people living with chronic hepatitis B over the last 15 years since we had our first national hepatitis B strategy launched. We are one of the handful of countries globally that could apply for recognition of path to elimination of hepatitis B. We probably have already achieved the bronze level of that, and silver is possible if we intensify our efforts. And successive national strategies with committed targets and indicators have really provided a framework for this, for reporting against these indicators. And the new sources of data, such as PLIDA, which I was referring to, can enhance our capacity for more complex and nuanced analysis and look at some of the intersectionality behind what we're seeing in these different populations within the country. However, nearly 70,000 Australians living with chronic hepatitis B and remain undiagnosed. 165,000 are not receiving regular care, and less than half the people who currently require treatment are receiving it. And this is why, along with the aging of the population of people living with hepatitis B, we're seeing increasing loss of life due to chronic hepatitis B. And some of the disparities in access to care between jurisdictions, across priority populations, reinforce the need for the equity targets in our strategy and for trying new approaches and for investing in actions that have already been shown to work. So I'd like to thank the whole team, and as I said, particularly Ang, Beth, Jen, Nicole, and Rasheen, who are active in the Indicators project. And I'd like to thank you all for your attention today. And with that, I'll stop sharing and open up hopefully for some questions.